So I will start with Hadley. Hadley, is there any advice you would offer to our early career researchers to help them grow into independent and impactful researchers working in health economics, genomics, precision medicine, or any other field that you feel is relevant to this group?
My biggest piece of advice to young researchers is always to follow your curiosity. It can take substantial creativity to bring together all of the relevant parties that are important to engage with when you are conducting economic evaluations in genomic medicine. So don't be afraid to forge your own path and combine training in various disciplines to work across multiple different groups of interested parties. The effort that you often need to put in to kind of forge your own career path can pay off in the end.
Thanks, Hadley. Mel, would you like to comment on the same question?
Yeah, my response is fairly similar. But I guess my key piece of advice is to not be afraid to just follow your own path. You don't have to do the same thing as everyone else. I've had quite an atypical academic career. I started with economics training first as an undergraduate. Then I went and trained as a clinician and worked in a hospital for 10 years and then came back into academia much later on. And this meant that I've spent a lot of my career looking at other people and thinking I'm not at the same point that they're at, and constantly feeling that I'm not up to scratch and not where I should be. But that was for me the best path, and it's meant that I've been able to do a lot of original research and think about things in a different way to other people. So there's no right or wrong way to follow your academic career, and you just need to sort of do what fits your skill set and your interests, and not worry about constantly comparing yourself to what everyone else is doing.
Thank you, Melanie. One last question, which relates mostly to the topic that we're discussing today. So, Hadley, why equity? Because it's quite a hot topic at the moment, and what got you into it?
As Dee Dee mentioned, I have a background in the study of ethical, legal, and social implications of genomic medicine. And so considerations of equity have been kind of a core part of that conversation for a long time. It is exciting that we are seeing more enthusiasm and methodological interest in developing ways to quantify equity impacts within health economics as a field, and potentially more interest in from decision makers in incorporating those quantitative estimates of impact as well. So equity has been kind of a long-standing interest of mine within genomics and precision medicine, and it is nice to see kind of the ethics and social science world colliding with the health economics world on this topic.
Thanks, Hadley. Mel, would you like to comment on that? Because you had quite a diverse background, and then now you're working on equity.
Yes. So when you work in the clinical space, you see the implications of inequity in socioeconomic status play out regularly. And I guess as a health economist, there's a bit of a disconnect between, what we see in clinical practice and then how that's actually evaluated through our health technology assessment frameworks. So I was just really interested in trying to find more robust ways that we can actually account for this and make it sort of a more routine part of our health technology assessment.
Thank you. So Melanie, would you like to start now your presentation? Looking forward. So if you can unmute yourself, thank you.
Yep. Can everyone see this in?
Yes.
Oops, sorry, I'm just trying to shrink everyone. Sorry, I've just lost my slides. I can see everyone and I can't see my slides.
We can see your slides, but yeah.
It's the view. There we go. Okay.
Thank you.
Thank you. So today I'm going to speak about a study that we've just recently completed on distributional cost effectiveness analysis of antenatal lifestyle interventions to reduce the incidence of gestational diabetes. So obviously this is not a study on genomic medicine, but given that this is a really new area of health economics, and there's very few completely specified distributional cost effectiveness analyses that have been completed globally, because there's still some key gaps in the underlying database that we need to be able to progress this work. But this is just a really nice example of how this sort of methodology can be applied. And because we did have most of the data that we need, it's a really nice way to illustrate the methodologies and get people thinking about how they might be able to use this in their own work. So I'd just like to thank all my collaborators. And this study was supported by the Health Economics and Policy Evaluation Research Group at Monash University and an Australian government MRFF grant. And we don't have any conflicts of interest to declare in relation to this work. So the background to this study, antenatal lifestyle interventions involve providing individually tailored coaching to promote healthy lifestyle choices during pregnancy, with the goal of reducing gestational weight gain and the incidence of adverse pregnancy outcomes. There's now level 1 evidence that supports the effectiveness of these interventions for reducing the incidence of gestational diabetes, and they've also been shown to be highly cost effective. But they're projected to cost the health system approximately $50 million per year to provide this intervention to all 300,000 pregnant women in Australia as part of routine care, which has necessitated targeted preliminary implementation to reduce the budget impact. So we therefore set out to investigate whether consideration of relative socioeconomic advantage can help us target our implementation strategy to reduce inequity in health. So we compared current standard care, which is no lifestyle intervention currently in Australia, with 4 different implementation strategies. So the first one was providing the antenatal lifestyle intervention to all pregnant women. Secondly was just providing it to women giving birth in the public health sector in Australia. Thirdly, just providing it to women with a body mass index over 25, and fourthly, to those with age of 30 when they became pregnant, age of 30 or above when they became pregnant. So the DCEA extended a previously published cost utility analysis, which estimated the cost effectiveness over the lifetime for implementing the antenatal lifestyle intervention into routine care for all Australian women giving birth in 2024. So this was just a standard cost effectiveness analysis that everyone's familiar with. So this analysis used a decision model to first estimate the impact of the incidence of gestational diabetes, and then that was followed up with a Markov model with life table modelling to project the impact of reducing the risk of gestational diabetes on lifetime incidence and outcomes of type 2 diabetes. And this is because we know that women that have gestational diabetes during pregnancy have a 10-fold increase in their risk of going on to develop type 2 diabetes later in life. So how do we extend this straightforward cost effectiveness analysis to incorporate distributional effects? Firstly, what is a distributional cost effectiveness analysis? So DCEA extends traditional cost effectiveness analysis to facilitate insights into how interventions, when implemented at the population level, influence the overall lifetime health of different equity relevant subgroups. So a distributional cost effectiveness analysis therefore provides information about both efficiency in terms of incremental costs and effects, but also equity in the distribution of costs and effects, both at baseline and after implementation of a new intervention. The equity relevant subgroup of interest is considered at all steps of the process in this model. So a helpful way to understand the key steps in a DCEA is to compare how these relate to steps in a traditional cost effectiveness analysis or cost utility analysis, because most health economists are familiar with those methodologies. So everyone knows how to do a cost effectiveness analysis, so we can work through systematically to explore how to get from a cost effectiveness analysis to a distributional cost effectiveness analysis. The first step is the first key difference. So distributional cost effectiveness analysis relies on knowledge of the baseline distribution of health across equity relevant subgroups of the population. This is a fundamental departure from traditional cost utility analysis, which assumes that everyone has equal baseline health. So in a distributional cost effectiveness analysis, we need to firstly select the equity relevant subgroup, and this can be anything that decision makers consider to be relevant to their decision question. Secondly, we need to determine how health will be measured in the population. So example, health adjusted life expectancy. And then we need to obtain the distribution of health stratified by the equity relevant subgroup. So there's multiple methods for estimating health adjusted life expectancy, including calculating lifetime expected QALYs or DALYs. In Australia and the UK, the standard practice has been to estimate quality adjusted life expectancy, QALY, by adjusting life expectancy by health utility. For our baseline distribution of health in our study, we use the recently published QALY norms for Australia, stratified by socioeconomic index for area quintiles. So socioeconomic quintile was our subgroup of interest. For this work, we estimated that average QALY at birth for the most advantaged quintile was 11 years greater than for the most disadvantaged quintile. The second step in the DCEA is to derive incremental costs and effects of intervention, which is a standard cost effectiveness analysis methodology. However, DCEA takes this a step further to calculate incremental costs and effects in each equity relevant subgroup. Population factors such as prevalence and uptake across the equity relevant subgroups should also be considered. So it's helpful to think about this process as a staircase of inequality, working through the questions of who should get the intervention, who does get the intervention, what does the intervention do, and what are the long-term effects on health. We therefore need to consider whether prevalence, uptake, adherence, clinical outcomes, mortality, and QALYs may differ across the equity relevant subgroup that we've selected. Cost effectiveness analysis was completed as per the previous published model, but here we stratified our inputs by implementation group and by CEFA quintile, which is our subgroup of interest, as we listed here. So data was taken from the Maternity 2000 and National Diabetes Services Scheme registries. So we had population level data for these variables and from the literature. Other than treatment uptake, treatment effect, per patient costs and discounting, all parameters included in the model were stratified by CEFA quintile to capture as many sources of inequity as possible in the modelling. We started with a basic cost, utility and budget impact analysis. So 240,000 women would receive the lifestyle intervention under the all women strategy. 43% of these would still remain eligible if the intervention was limited to those with a BMI greater than 25. 62% would be eligible if it was limited to women over the age of 30, and 74% if the intervention was provided only to women giving birth in the public sector. Incremental costs and QALYs were highest for the all women strategy and lowest for the BMI greater than 25 strategy, which reflects differences in the size of the eligible population for these strategies. However, BMI greater than 25 was the most cost-effective strategy, as evidenced by it having the lowest ISA. However, we can also see here that all strategies were cost-effective at the established Australian cost-effectiveness threshold of $50,000 that's used in decision-making. So the next step is to estimate the incremental net health benefit, introducing opportunity costs. Health opportunity cost refers to the health benefits that could have been achieved if the resources spent on a particular intervention were instead allocated to the next best alternative intervention. Opportunity costs must be considered in a distributional cost effectiveness analysis because limited health resources dictate that policymakers must choose between alternative interventions and the populations that receive them. When funding is directed to a new intervention, QALYs are sacrificed elsewhere in the population. This monetary value of a QALY is referred to as the health opportunity cost threshold, or the marginal rate of transformation between expenditure and health. The opportunity cost threshold is analogous to the decision willingness to pay threshold that's commonly applied in cost utility analysis, which reflects how much the social decision maker is willing to pay for a QALY gain at the margin. However, the opportunity cost threshold is typically somewhat lower or less generous than the decision threshold, which in turn is typically somewhat lower than the general public willingness to pay for a QALY. So here's the equation that most of you should be familiar with, that's used to determine net health benefit. So here the aim is to convert incremental costs or the opportunity cost of the intervention to QALYs so that net health benefit can be measured on a single scale in terms of incremental QALYs. K is the opportunity cost threshold, which varies between countries and settings and is often dictated by accepted health technology assessment policy. So when we looked at the net health benefit or the efficiency gain in our model, we applied a base case opportunity cost threshold of just over 31,000, which was taken from the literature. And we see that both the BMI greater than 25 and age greater than 30 years strategies had the highest incremental net health benefit. So implementation based on clinical risk, so our clinical risk groups, is the most efficient strategy for our intervention. So step 4 is then to estimate the incremental population level health gains stratified by the equity relevant subgroups. So this is not completed in a cost effectiveness analysis, but in a DCEA, the opportunity costs are distributed back to each equity relevant subgroup according to the relative proportion that is borne by that subgroup. And we use this to derive the total net health benefit for each subgroup. In a DCEA, we need to set both the opportunity cost threshold and the proportion of opportunity costs that are borne by each equity relevant subgroup. So this is an example of the distribution of opportunity costs that was estimated for England. Here, a greater proportion of the opportunity costs were borne by females in the most disadvantaged quintile and the least by males in the most advantaged quintile. So this is a distribution that we applied in our base case because we don't have knowledge of how the opportunity costs are distributed in Australia currently. And then we tested this through a variety of sensitivity analyses. So step 5 is to estimate the incremental per person net health gains or losses for the population. So in a cost effectiveness analysis, total net health benefit is sometimes expressed per intervention recipient, although this is somewhat misleading insofar as opportunity costs are borne also by non-recipients. In a DCEA, the net health gain or loss is the average per person incremental health, which can be derived by dividing the equity subgroup by the total population, both treated and untreated in that subgroup. So in our study, all implementation strategies benefited the most disadvantaged quintile the most. Only the public sector implementation strategy had a negative impact on the health of any group, which was the most advantaged quintile. So C for 5, the yellow column you'll see is below 0. So there was a loss in net health for the most advantaged quintile for that implementation strategy. Step 6 is to derive the population level equity impact. So now we're moving on to the equity gain, as opposed to the efficiency gain. So in a cost effectiveness analysis, this is not completed. In a DCEA, the incremental net gain or loss is compared between the subgroups. Summary measures of health inequality impact magnitude is calculated in quality units, such as the change in the simple health gap between the most and least socially advantaged groups. So next we can look at the simple health gain in our model between the most advantaged and the most disadvantaged quintiles. So the absolute QALY gap is the difference between total lifetime QALYs for the most advantaged population quintile minus the total lifetime QALYs in the least advantaged quintile. If the change in absolute QALY gap is negative after intervention, this implies that the gap in health between the most advantaged and least advantaged quintiles has been reduced. So we see here that all our strategies reduced inequality, but implementation in the public system was the most equitable strategy. So the final step for our DCEA is to incorporate inequality aversion weighting to enable the decision maker to trade off between equity and efficiency. So in a cost effectiveness analysis, this is not completed. In a distributional cost effectiveness analysis, we determine the strength of the decision maker's concern for reducing health inequality versus improving total health. And then we weight the net health benefit to explicitly integrate the decision maker's degree of health inequality aversion. Weighting an unequal health distribution enables derivation of equally distributed equivalent health, EDH, which measures the average level of health in a perfectly equal health distribution, where all equity categories have the same total health, that the relevant decision maker considers to be comparable to the current unequal health distribution. So in other words, an inequality averse decision maker may be willing to accept a lower level of overall health in the population if the distribution of health is more equitable. If there is inequality in health, which the decision maker has an aversion to, the EDH will be lower than the total population quale. So here we have the equations for EDH based on the Atkinson index, which is a commonly used social welfare function in DCEA, and it's the social welfare function that we applied in our study. So these rely on the Atkinson inequality aversion parameter, epsilon. When epsilon equals 0, inequality is ignored and the goal is to maximise total health in the population. When epsilon approaches infinity, only the well-being of the most disadvantaged group is prioritised. So in our study, we applied in the base case an Atkinson IAP of epsilon equals 7, which was taken from a recent study of the Australian population's general level of aversion to inequality due to income or due to socioeconomic advantage. So I think this is the first DCEA that's applied this new metric. And when we applied this, we see that, as before, the net equity impact was greatest for the public system. And we also remember from earlier that the greatest efficiency was seen in the BMI greater than 25 group. So BMI greater than 25 is the most efficient strategy, while the public system implementation is the most equitable strategy. So how's a decision maker supposed to choose between those two circumstances? So this is what's called an equity efficiency plane, which is fairly similar to a cost effectiveness plane that's used in traditional cost effectiveness analysis, except here on the vertical axis, we have the incremental population net health benefit. So this is the efficiency. And on the horizontal axis, we have the population net equity impact. So the change in equity within the population. So we can plot our 4 intervention strategies on this plane. So we see that age and BMI are the 2 most efficient strategies, while the public implementation strategy is the most equitable. So public offers a small equity gain, but it's at the expense of a larger loss in efficiency. And we can determine this by looking at the incremental population EDH. So this statistic incorporates through the weighting both efficiency and equity. So it gives us an answer on balance, given the level of inequality aversion in the Australian population, that this decision maker should prefer the BMI greater than 25 strategy. Our results were also robust to changes in the level of inequality aversion. So BMI greater than 25 was the preferred implementation strategy at all levels of the Atkinson IAP that were explored between 0 and 20. We also conducted sensitivity analysis to investigate the impact of using an equal distribution of opportunity costs rather than applying the English opportunity cost weights. We varied the opportunity cost threshold between $20,000 and $50,000 per quality. We looked at discounting of 0% and 5% instead of the 3% in the base case. We found that the all-women strategy was most sensitive to variation in input parameters. And this is unsurprising given it's the largest and most heterogeneous population. And we also found that there was no change in the study conclusion from these sensitivity analyses. The key strengths of this study were its use of population level registry data, and there's also a comprehensive evidence base supporting the intervention. So efficacy, effect modification, uptake, and adherence inputs are all strongly supported by the available evidence. The key limitations were a lack of long-term outcomes data from clinical trials, because the onset of type 2 diabetes after gestational diabetes can happen 15 to 20 years in the future, and none of the clinical trials have follow-up that long. The distribution of opportunity costs by socioeconomic status is unknown for Australia currently, so we had to rely on the UK values, and we're unable to complete probabilistic sensitivity analysis. And this is because we cannot reliably estimate the covariance structure of key input parameters with social advantage group. And assuming independent variation of each group would substantially overestimate uncertainty in the health inequality reduction. So in conclusion, while none of the results of this study are really surprising, they align fairly closely with what our hypothesis was, but it's very helpful for us to have robust data to support health policy decisions when we're speaking to government about getting these interventions funded. We found that all implementation strategies were cost effective and all improved equity. However, providing the intervention to all women requires a very large budget, which we are not currently able to secure. So when we give consideration to both equity and efficiency, this study supports preliminary implementation of a fully subsidised antenatal lifestyle intervention for all women with a pre-pregnancy BMI of greater than 25. Thank you.
Thank you. Thank you very much, Melanie. That's a great talk. Now I'm giving the floor to Hadley to do her presentation. Hadley, looking forward to your talk. Thank you.
Thank you, Jensina, and thank you to the organizers for the opportunity to present. Today, I'll be talking about distributional cost effectiveness analysis specific to genomic medicine. My talk is a bit more conceptual than Mel's, so I think a nice complement. So I'll start by talking about equity in considerations in genomic medicine broadly, and then I'll walk through the steps of specifying an existing conceptual framework, the staircase of inequality, to think about conducting DCEA within the context of genomic medicine interventions. I'll conclude with some thoughts about how DCEA may inform genomic medicine implementation decisions and some research next steps in order to further that research agenda. So there are complex interrelated sets of factors that contribute to disparities in both access to and outcomes of genomic medicine interventions. And these include healthcare system, research, and data-related equity issues that I will expand on throughout this talk. So definitions of equity within genomic medicine have traditionally emphasized the importance of global knowledge sharing and access to genetically informed care. Take, for example, this definition of health equity in genomic medicine from Juma and colleagues at the National Institutes of Health from 2019. They define health equity in genomic medicine as global applicability of genomic knowledge, fair and even access to genomic services such as testing and counseling, and unbiased implementation of genomic medicine. So in contrast with this focus on equity in knowledge sharing and implementation and access, DCEA is concerned with the impacts on health outcomes. So DCEA can be useful to inform deliberations about implementing genomic medicine interventions in a way that advances health equity, that is consistent with the Whitehead notion of equity as absence of avoidable differences in health among socially defined population groups. So Mel has done a nice job of setting up the contrast between traditional cost-effectiveness analysis and distributional cost-effectiveness analysis. And that raises the question of how well do traditional cost-effectiveness analyses serve to advance health equity in genomic medicine? Might a traditional CEA be efficient? So there's longstanding concern that genomic medicine interventions could exacerbate existing health inequities. Social scientists studying the ethical, legal, and social implications of genomics have produced much conceptual and empirical scholarship that analyzes equity from a normative and an empirical perspective. There are these system-related, data-related, and patient factors that play into this potential to exacerbate health inequities. And this is one of the reasons why application of DCEA within the field of genomic medicine has particularly exciting potential. Even though there is this robust scholarship around equity impacts in genomic medicine, ethics and inequality are very rarely considered in economic evaluations of genomic medicine. When we think about applying traditional CEA to rare disease, that raises questions about underlying social values, as well as the appropriateness of outcome measures such as the quality adjusted life year. One potential solution is to use a higher cost effectiveness threshold for products that target rare diseases. While this serves a notion of vertical equity in the sense that there is an unequal application of thresholds that may be equitable, it does not serve a notion of horizontal equity, which would require that the same threshold be applied across all condition areas. So traditional cost effectiveness analysis aims to inform decisions that improve total health in a population. And it is rooted in the ethical principle of value maximization. It is not, however, suitable to address equity objectives such as reducing inequality in health or improving health in a small number of severely ill patients. Distributional health cost effectiveness analysis aims to inform decisions that maximize social welfare in a population and involves these equity efficiency trade-offs, which Mel described. It can be used to characterize the effects of healthcare interventions in terms of the distribution of benefits and burdens among population groups, and relies on that numerical index to rank health distributions. Embedded within that index is a value judgment about the appropriate trade-off between reducing unfair health inequality and improving total health. So in genomic medicine, we're often thinking about the target population as consisting of a small number of individuals with either rare disease or subtypes of a common disease. And so distributional cost effectiveness analysis has particular advantages here where we may be less concerned about improving total health, but we may be concerned about improving health for a small number of severely ill individuals. So there is growing interest in applying DCEA to genomic medicine topics, such as treatment informative non-small cell lung cancer treatment and gene therapy for sickle cell disease. And so along with my collaborators, we wanted to lay out some considerations for applying distributional cost effectiveness analysis in the genomic medicine context. And we've published this paper earlier this year in Value in Health, in which we specify the existing staircase of inequality for the genomic medicine context. This is an existing conceptual framework for understanding the causal pathway between an intervention and outcome distribution amongst social groups. When applying DCEA in genomic medicine, careful attention should be paid to the extent to which various factors may or may not be correlated with equity relevant social factors. And that includes genetic factors such as variant prevalence and expressivity, as well as healthcare system factors such as access to genomic medicine interventions and follow-up care. So this is the staircase of inequality. And as you can see, we have specified each level within the context of genomic medicine. I will walk through each of these levels over the next several slides. The first step in the staircase of inequality is need. And in the context of genomic medicine, we define need to be related to the prevalence or incidence of a genetic condition or a specific variant associated with disease. Need may vary according to genetic similarity or genetic ancestry, and it may be correlated to some extent with social group identity. Environmental factors that operate at the social level can impact genetic factors, specifically epigenetics, at the biological level. These epigenetic factors can affect the extent to which a disease manifests and the severity of the disease. Level 2 in the staircase of inequality is receipt. This relates to access and uptake of a genomic medicine intervention. Population subgroup receipt of genomic medicine may vary due to system-level barriers to access to that care that may be related to payment or reimbursement, as well as geographic access. Genomic medicine services are typically centralized within academic medical centers that tend to be in urban environments, may not be geographically accessible to all patients. There are also patient-level factors that may be relevant to receipt of care. There are preferences and values that influence genomic medicine uptake. Patient experiences or priorities may also influence research participation that influences the data available for clinical interpretation of genetic test results. The third and fourth levels of the staircase are short-term and long-term effects. We think about short-term effects as clinical validity of genetic testing. Clinical validity is related to genetic diversity in existing databases, so related to that research participation, which I just mentioned. So in databases that are used to establish causal linkages between genetic variants and human disease, people who are of ancestries other than European ancestry are underrepresented. And so for those populations that are underrepresented in existing databases, disease risk estimates may be less accurate. When we think about long-term effects, that relates to the clinical utility of genetic information to inform targeted interventions or disease management strategies. Clinical utility is related to the availability of such targeted interventions, and it may vary by subgroup based on factors that drive that treatment development, adoption, and reimbursement. The fifth level is health opportunity costs. So beyond the target population of an intervention, adoption of genomic medicine interventions may impact general population health opportunity costs. If a population-based genetic screening, for example, for a condition with higher prevalence in a given socially defined group is implemented, it can lead to unequal health opportunity costs in the general population. There are several data considerations for DCEAs in genomic medicine that should be considered by any analyst who is planning to take on such an analysis. So data on genetic similarity and its variation in socially defined groups is rarely available as part of data sets that are typically used for cost effectiveness analyses, requires individual patient level data. Subgroup specific estimates are needed for the DCEA when it is believed that distributions of patient characteristics differ between equity relevant subgroups, and when patient characteristics influence the clinical validity, clinical utility, treatment effectiveness, and resource use and costs associated with the intervention. Analysts should express caution when using data from study populations that differ significantly from the DCEA's target population because these factors may differ between study populations and the target population that could result in biased results. And precise descriptions of genetic similarity and social factors should be collected when possible in prospective data collection studies. So as we think about next steps for moving this research agenda forward, there are a couple of key considerations that my co-authors and I outline in this paper. The first is to understand whether and how the genetic basis of disease may impact inequality aversion in a population. The second consideration is to consider the distribution of non-health outcomes, as well as health outcomes from a genomic medicine intervention. We know that there are important non-health benefits such as enrollment in therapeutic clinical trials or accessing family support groups that may be relevant. The third consideration is to empower populations that are underrepresented in genomic research, because as an analytic tool, DCEA will not address any upstream data equity considerations. And the final recommendation is to collect data accurately assess variation in genomic medicine outcomes across equity relevant population subgroups, and considering clinical validity and utility as well as treatment effectiveness. So is there a potential role for DCEA in health technology assessment moving forward? Traditionally, health technology assessment has incorporated equity considerations in more of a qualitative manner and through deliberation. However, DCEA allows for consideration of equity within a quantitative framework, and that may actually increase the transparency around how equity considerations are incorporated into decision-making. The ability of DCEAs to provide empirical evidence regarding expected impact of an intervention on equity can serve important goals that decision makers may have. And other factors will still need to be considered alongside the results of DCEA in the decision-making process. We do not make any suggestion that it should take the place of deliberation. As we think about using DCEA to inform policy and implementation decisions, it's important to recognize that it will not solve equity problems in genomics in and of itself. Data equity and access issues must be addressed through other means, and ongoing complementary social science research is necessary to increase the equity of outcomes in genomics, including building trustworthiness of genomic research programs, improving access to genomic medicine, and understanding patient preferences and how they may differ amongst population subgroups. So to the extent that genomic medicine operates at a level that is correlated with social factors, DCEA is suited to address the social disparities in health that result from it. Quantification and transparency Quantification may add transparency to considerations of equity, and application of DCEA will require careful consideration of factors that can influence outcomes at each level. So thank you to my collaborators. I look forward to the Q&A.
Thank you so much, Hadley. That's a great presentation. So I'm opening now floor for questions. For Melanie and Hadley, we already have one question for you, and it relates in the context of, do you have any experience, comments about the feasibility of distributional cost-effective analysis that don't use quality-adjusted life years? Is that possible? In genomics, often the outcome is cost per diagnosis. So we know there is some data that has been presented in terms of other outcomes, but I would let you, Hadley and Mel, to comment on that beyond QALYs. What other outcomes can be used in distributional cost effectiveness analysis? Mel, Hadley, which one do you want?
I'm happy to go. I think because thus far this work is still very much in its infancy, and so there's still lots of work happening just around defining population health and how this should be applied in that sense. But yeah, I think there is potential that we can expand beyond that. So in particular, thinking about potentially things like productivity or participation in work. And whether there's distributional impacts for interventions on those sorts of outcomes as well.
Great. Hadley, do you want to comment on cost per diagnosis? Have you had a case study that this was used, or any tips on that?
I have not done this analysis myself, but I would say it seems reasonable that one could think about outcomes other than equality within that intermediate step of where you're quantifying the impact on the target population. So it seems feasible that you could consider a distribution of outcomes by population subgroup within that target population.
Thanks, Hadley. We have a question from Mackenzie, and Mackenzie's question is around how do you see this analysis in Australian context being implemented as a subgroup analysis, or and context where HTA bodies don't have a pre-specified threshold. For example, DCEA might be really powerful if you could move an ISO to be cost effective, but if the funding bodies look at equity impacts more qualitatively, does distributional cost effectiveness analysis add additional value over more standard approach that we use in a current HTA?
Yeah, definitely. So sort of, I guess, two of the key areas where this is particularly useful is for those interventions that are not particularly cost effective or have a, you'd need a high threshold for them to be cost effective, but they have a very big impact on equity because that's sort of quantifying that additional dimension of value for the funding bodies. And the other useful scenario is the one that I used in my case study, where you've got an intervention that's really cost effective and really effective, and there's lots of evidence to support that. But because we're talking about such a huge intervention, the federal government's not going to agree to spend $50 million per year on a new intervention that hasn't been tested in routine practice. So we have to choose where we're going to start in terms of getting this out there. And this allows us to actually quantify the equity impact of different implementation strategies. So rather than just looking at which are likely to have the biggest net health benefit, we can actually really consider equity as well, and particularly because diabetes is a lifestyle disease. We know that it tends to be concentrated in socioeconomically disadvantaged communities. So that's a really important dimension, I think, to consider for this intervention. So it's just like an extra way to lobby in terms of getting focus on these groups and these interventions.
Thanks. We have another question from Anaga, and she has two technical questions for Melanie. The first one is, if I understood correctly, the sensitivity analysis shows that the high levels of aversion of inequality, the application based on BMI was still on a higher social value than applying the intervention to everyone treated in the public system. What is that, considering the inequality impact was largest for the latter? So we'll go with question one first.
Sorry, is it written in the chat? I'm just going to
Yeah, it is. It is.
Sure,
it's around sensitivity analysis and an application of on a BMI was still on a higher social value.
So it was when we look at, because BMI was the most efficient application because you're getting high risk patients there. So you're targeting the people that sort of have the greatest clinical need. So that sensitivity analysis was for the EDH, which is the statistic that balances both equity and efficiency. So regardless of what level of aversion we looked at. So even highly inaverse, so people with a high level of aversion, even when we do that, the equity gain that we get from the public system is not enough to offset the efficiency gain for the clinically focused group. That's what that sensitivity analysis showed, if that makes sense.
Yeah, and the second question is, what do you think about using CIFA for distributional cost effectiveness analysis, knowing that in Australian context, instead of basing the choice of social groupings on the context of intervention, for example, we know that GDM is highly ethnically patterned. So would this not be a useful grouping for this example?
Yes, that's very true. And it would, yes, be an interesting grouping to examine. We were limited in this case by the available data. We wanted to do as close to complete DCEA as possible. And given that we only have QALA norms for Australia at the moment for educational attainment and rural regional, and their CIFA groupings, we were sort of limited to one of those. This was also a hypothetical exercise because we didn't have a targeted decision maker. So we were just kind of saying that we think this is a group that people should be interested in, but generally for a DCEA, if you're working alongside a government group or a pharmaceutical benefit scheme or whoever it is that you're helping to make this decision, you would be asking them about what socially relevant group they want to have examined. And there's still lots of work going on in Australia at the moment as well to actually define which groups we should be focusing on. I know Melbourne University are also looking at Indigenous status as an important Australian relevant socioeconomic subgroup of interest for equity. So that's another one that we probably need to consider as well, that we just don't have data on currently.
Thanks, Mel. Hadley, would you like to comment on the last one? What is your experience in presenting distributional cost effectiveness analysis results to decision makers? Are these kind of results being used or applied in practice? And how sensitive are results to the values for the social welfare topics?
I lost my internet connection to the Zoom room, but hopefully you can still hear me.
Yes, we can. Thank you.
Okay. So I don't have personal experience of presenting DCEA results to decision makers. I know this is a rapidly evolving area around the world where decision-making bodies are considering whether and how they may incorporate DCEA results formally into decision-making processes. And I think that there are many groups that have stated they are not yet ready to consider DCEA results formally, but may at some point be open to doing so.
Yeah. Thank you so much, Hadley. I think we have one last question. If people are okay to answer this, I'm more than happy to go for another 1 minute. So this is a question for Melanie. Sorry, it's from Anita Lal. So sorry if I misunderstood, but I think equity weights were applied when the interventions was cost effective. Why was this done?
Yeah, so this is following on from my answer before. So within a health technology assessment framework, ideally, if you've got a standard threshold and an intervention is shown to be cost effective against that threshold, it should just be funded. That's kind of the framework that we work within. However, because this intervention, we're talking about providing an intervention to 300,000 women per year. So it's a huge and very expensive intervention. And despite there being level 1 meta-analysis evidence to support the intervention, which has been in existence now for about 4 years, the clinical groups are not having success at either state or federal government level getting this intervention funded. And there's lots of arguments about who should fund it and where it should sit and how it should work. So this was just our way of, I guess, adding some more information to that conversation, that if it's like another piece of the puzzle. If decision makers understand that not only is this a cost-effective intervention, it's also improving equity. So it's another argument to support getting this into routine practice. And it's also helping us to guide our decision making about where we should start if we're not going to make it available to everyone, if we're going to focus on particular groups initially, while we test how it works and how the framework's going to work in routine practice. Where should we start? And if the government decides that they want to focus on groups based on, like, for a political reason, they want to improve equity, then now they've got the data they need to make those arguments to pick that particular group.
Thank you, Melanie. Thank you, Hadley, for wonderful 2 talks. We've learned so much. Thank you to Economics Genomics for organizing this amazing series of talks. I thank you all for participating. It's been an amazing to see so many of you coming and asking questions. It's a very important topic. And see you in the next round of the topics. Didi, do you want to say something?
The only thing I was going to say is thank you to everyone for joining. And if you're interested in, connecting with us about today's talks, or finding out about future events, or volunteering for future talks, then please do reach out to us on our social media pages. You can see our accounts are linked to here. Thanks, everyone, and thank you to our speakers.
Thank you.